Good evening. Hello, good evening.
Good evening, ma.
Yes,
evening,
I've been
doctor.
trying to join for the
Good evening, ma.
last 3 minutes. Good evening. I hope you all had a beautiful day. I hope you all had a good day.
Yes, ma. Yes, ma.
Yes.
Yes, ma'am.
Hello, good evening.
Good evening, ma'am.
Good evening.
Good evening, doctor.
Okay, people have slides. Can somebody share slide? Let us keep
Good
moving.
evening, ma'am.
Yeah, good evening, good evening, good evening. I usually get network like on my streets. So that's where I am now. I can't carry my laptop. I can only use my phone. So please let someone share the slide. I hope everybody have received the slides.
Yes, ma'am.
All
Yes,
right,
ma'am.
let somebody share the okay now. Or counselor, please, anybody should share the slide. Let's look at it quickly.
The fresh paper. Okay. Do commercial. Want to put over the
I hope this is a combined class. Counselor and Ikenna, I hope this is a combined class.
Yes, doc. Yes, it's a combined class.
All right, so can someone share the slide? Let's start. Okay, the PowerPoint. Have I taught you this? Have I shared this with you?
Doc, I think someone else should share. There is something that is blocking the screen. I don't want to bother people with that line again. So somebody else should share, please.
The screen is okay now.
Okay, let me do that. Let me try again.
It's clear. Nothing is blocking anything. It's okay.
It's clear enough. Me, my weather is not good. It might rain, so we are going to run. I don't know if I've shared this with you. Learning objectives, what is rehabilitation, what are the disciplines in rehabilitation. Some of these we have talked about. Major strategies, stages in rehabilitation, barriers, people who require rehabilitation, definition and classification, causes and management of handicap. All right. So I don't know if we have had this slide. Next slide, please, quickly.
Those format, normal phone, normal stuff.
Okay. Next slide. It's like we have managed this, isn't it? Next slide. I think I've discussed this slide. I just want to do geriatrics, and I think it's in this same slide. Geriatrics, elderly people, all these are examples or disciplines in rehabilitation, physiotherapy, audiology, occupational therapy. I gave you assignment to write the difference between occupational therapy and vocational therapy. So those are all the examples. Next slide. The members of the rehabilitation team we discussed. And we say most of the time the doctor is a physiatrist. All right. Next slide. Yes, it's an assignment, but you don't have to submit it, but you should research it yourself. Okay. We have done the definition of rehabilitation before. So next slide. Medical rehabilitation focuses on restoration of function, like the function of the pancreas, the function of the heart, the function of the kidney, the function of the liver. So restoration, that function, you talk about medical rehabilitation. The vocational rehabilitation restore capacity to earn a living. Social rehabilitation, restoration of family and social relationships. When somebody is socially rehabilitated, the person can now relate with others, all right? Can be restored to the family. Example of people, good example are people that have been cured of leprosy. Very, very important. Good example, you need to work as a rehabilitation expert, social medicine expert, public health expert, social worker to restore the person to his family. So families are not with the person.
It seems we lost Doc. I don't know whether it's from my end.
It's from my end, not yours.
Say we. Mbanu.
Okay. So sorry, I was just locked out. I just came back. So I talked about social rehabilitation, and I said a good example are sufferers of leprosy. They are ostracized, they are segregated against, they are stigmatized. Even family members don't want changes. It's such a disease that one is ashamed of, so they want to keep away from them. But as public health experts, we can restore them, do social rehabilitation, restore them to their family, friends, and community. How are we going to do that? First and foremost, we must arm ourselves with knowledge. Be able to first, we can talk to the family, let them understand that this person is cured. It wasn't his fault that he got the problem, that it wasn't, he got it due to he was infected. And okay, what are the measures to prevent, to deter
Jesus of
infections? You
Nazareth.
can, if you have the knowledge,
Oh, my baby.
if you
Because
have the
Natazo,
knowledge, you
after
tell
TV,
them.
other man, I knew. Natazo, I am.
So if you have the knowledge, you share with them why the person was infected and what
This is my
causes
consultant, ophthalmologist.
leprosy. So when you teach the family, friends, and community this, it's easier for them to understand. It's easier for them to accept that leprous person that has been cured now. So it's one good example of social rehabilitation. Then the people can accept them even back to their homes, back to their churches, back to their mosques, back to the communities. They can buy things from them unlike before. Nobody wants to touch them. Nobody wants to say a word to them. Nobody wants to buy things from them. So there's psychological rehabilitation, just psychotherapy, talking to people, know their problems, listening very well, encouraging them, and they're trying to find a solution together with them. It is psychotherapy, that's social rehabilitation. Next slide, please. Okay, what are the measures? How do you go about rehabilitation? It may be simple. Oh, it's a simple thing, but it's not just simple. It might appear simple, but it's not simple. It requires planning, pre-planning and planning. You need to plan, you need to pre-plan, you need to plan. Part of planning is have knowledge, have skill, have knowledge about the problem that you want to handle, problem about the persons involved, you want knowledge about the persons involved, and then the skill to be able to solve the problem. All right, so it requires planning, it requires it's systematic action. It's not just open your mouth and say anything. Okay, then you know what you need to use. Is it a surgical alone, medical, vocational? Usually it's a combination of types or disciplines that be able to achieve good rehabilitation. And it has, okay, together with counseling, health education, all right, level of functional ability. Next slide. Next slide, please. Okay, this is actually not properly arranged. So there are three major strategies. One is institutionalized, institution-based, like in teaching hospital here, we have physiotherapy department, but remember that is just physical therapy. And we also say that even internal medicine If there's rehabilitation, there's surgery, there's rehabilitation. So in institutions, there is rehabilitation, different parts of it, audiometry, speech therapy, much more can be in the institution. What is the disadvantage of when it's in an institution? Little attention is given to the person's family and community, or to the other relevant social factors like cultural factors and norms. What is the advantage of institution-based rehabilitation? Referral system is very easy, it's very possible, it's available. So when you are rehabilitating someone and you need the person to go and see the eye doctor, you can easily refer. You want the person to go and see the cardiologist, it's easy to refer and they can access that care. That's the advantage of rehabilitation in institution. Then there's the other one we call community-based, in that the rehabilitation is in the community. Usually the indigenous people do the rehabilitation. Every community have people that do rehabilitation. Is it the bone setter? Is some form of rehabilitation. And all the other people that are involved in rehabilitations in the community. Even physiotherapists are also in the community. We have community physiotherapists. Then in between is outreach, visits by rehabilitation personnel to the home of people with problems. Let me use problems now. Like people that have had stroke, and physiotherapists go to their homes to treat them. People that have had spinal problem, people that have had bone problem, that have had accidents, that have had other injury, people speech problem or hearing problem. The team goes to them to carry out the rehabilitation activity. So that's outreach. Next slide. Next slide. All right. Okay, I've talked about community-based rehabilitation, and my write-up says that it is characterized by the active role of the people with disability, their family, their community. So the families themselves are involved, community is involved in the processes. That means community participation is achieved. Next slide. All right. Assessment and identification of problems. It still needs to be planned, needs to be itemized, analyze the problem, then set goals. Then you list out your treatment interventions after examination, select and apply interventions to reduce disability and handicap. In essence, it's telling us that when there's a problem, we need to plan, we need to examine, we need to identify the gaps, the problems the person has. When you have done that, you set up your objective, your goals. You say, how do we go about making this person to work again? That's the ultimate goal. Okay, so you list out all the ideas, all the processes, all the interventions you may have to go, you might have to use. Then you administer your intervention, and then you evaluate from time to time. That is just okay. Next slide. In evaluation, you check effectiveness, you review your advice, you look for coping strategies for patients and caregivers. Next slide. What are the barriers to successful evaluation? Okay, have I given you assignments? Have I given you assignment already to submit? Hello? Hello? Am I not in class?
No, ma,
No,
you've
ma.
not given assignment.
Assignment.
No,
Okay,
ma.
that's good. All right. Okay, noted.
No, ma. No, ma.
Okay, my favorite assignment is that you should tell us the barriers to successful rehabilitation. Barriers, what is it that prevents people from getting rehabilitated? Please don't copy what is on this slide. Do your own note. All right? Do your own note. Barriers to successful rehabilitation. I think I've given you something to write up for CA. I'll remember. Next slide, please. I've given you as an assignment because this, even without reading it, you can think about barriers. What can prevent somebody from being successful rehabilitated? So you can divide it into two: a patient factor and system factor into two. Some people divide into three. All right. So these are the things that you think might be a hindrance, a barrier to successful rehabilitation. Next slide. Some people don't believe that the Western medicine will cure them. You know, they already believe, oh, it's a poison, it's jazz, and much more. So that sort of person is difficult to rehabilitate the person. I'm just giving you an example. But there are 1,001 examples out there. Okay. Examples of rehabilitation is um, somebody that has stroke and you rehabilitate the person can start walking, the person can start talking, the person can start doing so many other things, being independent again. Okay. Okay. Prosthesis from mutilation. Okay. I don't know why they refused me to unmute myself before. All right. So who is the famous athlete that is using prosthetics? Hello.
Oscar Pretorius.
Yes, thank you. Oscar Pistorius is using prosthetics to run. The blade man. So that's a good example of prosthesis. There's someone that works where I work. He has an hand amputated, so he wears prosthetics. I will call it artificial arm. Some people artificial eye. All right. So there's a prosthetic. Next slide. Those are all the other examples of rehabilitation. I am sure you can search out more and write it down for yourself. Next slide. Okay, people who require rehabilitation. In fact, one class I was teaching, when we said people who require rehabilitation, who requires rehabilitation? I said everybody, they shouted. They said they do not require rehabilitation. I say fine. By the time we go through it, you know that everybody, if not now, but soon, you require rehabilitation. Okay, so I have this list of handicapped persons, maternally deprived, motherless children, the aged, the destitute, street children, AIDS orphan refugees, people living with HIV/AIDS, juvenile delinquents, all right? Most of them are social rehabilitation, but there's also physical rehabilitation, medical rehabilitation. The pair of eyeglasses I'm using to be able to teach you what kind of rehabilitation is that? Hello, class.
Yes, Doc. We are
Hello,
good.
ma.
Hello.
Hello, ma.
Yes,
Ma.
ma'am.
Hello,
Hello.
class.
Yes,
Ma.
ma.
Hello, class.
Hello,
Hello,
prof.
ma.
We can hear
Ma.
you.
Next
Yes,
slide.
ma.
That's rehabilitation to be able to teach you. What form of rehabilitation is that? I'm using a pair of eyeglasses to be able to see well to teach you. What kind of rehabilitation is that?
Physical. Physical
Medical
rehabilitation.
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 I don't know.
Okay. Okay. Someone has said medical. I think it's more of medical rehabilitation. More of medical rehabilitation. Okay, next slide, please.
Ben's
That's all.
Thank you.
Is this the last
Prof,
slide?
Prof, we can't hear you clearly. Oh.
Okay.
Can
Can you hear me now? Can you hear me now? Can you hear me now?
we can hear you.
Okay,
Yes,
so we have
ma'am.
gone
Yes, ma'am.
into some definitions. All right, so the first is impairment. Impairment is any loss. I want to leave out or, and just use the first word. Any loss of psychological, structure, any loss of psychological structure is impairment. So if I read another one, any loss of physiological function is impairment. So physiological, like the kidney failing, is a physiological process. So when there's a loss, that is kidney failure, or there's abnormality, the kidney is failing, that is physiological function, that is a loss, is impairment. The definition has a lot of but you need to read it to understand it. I'm trying to break it down now. Any loss of anatomical structure is impairment. Example of anatomical structure is like fracture of the femur, fracture of the humerus, fracture of the jawbone, fracture of the fibula or ulnar radius, any of those things, of the skull, for example. That's anatomical. Any loss or abnormality. Now we are dealing with anatomical, like loss of teeth, for example. Anatomical structure, anatomy. Okay? So that is impairment. Then when one has impairment because of loss or abnormality, it could be loss, like completely lost. No, it's not there. Like there's a almost total kidney failure. Or kidney failure. That's a loss. All right. Heart failure, that's a loss. Some people their leg can be cut off completely. That's it. But if the person didn't have leg cut off, but it's broken, fracture, that's abnormality. Okay? Then what is disability? Disability emanates from impairment. When there's an impairment, it leads to disability. Disability is inability, unable, inability. They say my volume is too low. Okay, so disability, I'm shouting. Disability results from impairment. Let me use myself as an example. My visual acuity is poor. It's reduced. It's no more 6/6, 6/6. All right? I cannot see well. I have this, I'm unable to see well. All right? And if I'm unable to see well, I have a restriction. Okay? I have a restriction. I cannot see well. Then if I cannot see well, I cannot read. I cannot write. If it gets to that level, I can't read, I can't write. I won't be able to earn a living. I won't be able to teach. I won't be able to go to school. Then I have become handicapped. I wish you can be following my just my own example. I'm become handicapped. Then with that, I need rehabilitation. This will happen without intervention along the way. But if there's no intervention, you become handicapped. And how can we rehabilitate me? I had to go see the eye doctor, the ophthalmologist, who examined my eye, made a prescription. I went to the optometrist. I was given a pair of glasses, which I'm using right now to be able to teach you without much problem. That is rehabilitation. The man that rides Okada to feed his family, pay school fees, take care of his needs. Is okay. So the man that rides Okada now has an accident and has a fracture. The fracture is, the bone is broken, like the femur is broken. So there is abnormality of anatomical structure. That is impairment. He's unable to walk. If he's unable to walk, he's unable to even ride his Okada. He has disability. He is unable to. That's disability. And when he has disability, he will not be able to ride his Okada to earn a living, to feed himself, feed his family, pay his rent, and much more. He has become a handicapped individual. So that's how it goes. I'm sure you can give 1,001 examples. Can I get an example from the class, please? Can I get an example from the class? Please speak up. I'm not seeing your hands, but let me get examples from the class, please. I've given my own examples. Hello.
Good evening, ma.
Hello. Hello, ma.
Good evening. Yes, good
Good
evening. Yes.
Okay, an example is, for instance, a driver that does driving for an occupation, and he lost both eyes due to an accident. Losing those eyes is an impairment. Then inability for the driver to see with those eyes is already a disability. Then because of those, he cannot see with those eyes. He
Losing
cannot
the
continue
eye
with
is
the
a loss of anatomy, anatomical loss.
Yes, that is an impairment.
Do you get it? Yeah, that's impairment. Yes, very good.
Impairment. Then inability to see with those eyes because he has lost
So
those
what's
eyes.
the
Inability to
disability
see.
there?
The disability is unable to see.
Very good. So what now happens to him?
The handicap,
Yes.
being a
What
driver, he needs
happens to
those eyes
him?
to see to drive, so he cannot drive to provide for his family. Hello?
Yes, so he has become handicapped, right?
Handicap, yes. Yes, sir.
Yes, I'm
Yes,
with
ma'am.
you.
Yes, ma'am.
Okay, so how do you rehabilitate such a person? How do you rehabilitate such a
You
person?
can, if there's, I don't know if it's being carried out for, you can, I don't know how, if it's being carried out, but I know that kind of person, you can enroll that kind of person in this kind of, in a school, writing school, or change of occupation. Most likely, he has to change an occupation, and also you can, if you say somebody that is a learnable or somebody that is, how would I put, somebody that is that is, hello. Hello.
I'm
Oh
here.
yeah, again. Hello.
A special purpose vehicle can be
Why are some people making noise in class? Please
But I vote to say
tell
let
them
the
to stop
co-host be
making
muted
noise.
or they should mute everybody.
Tell them to stop making noise.
Please, oh, mute everybody now. Mute everybody, oh.
All right, so please, that was a good example. And we're saying, how do we rehabilitate the man that lost his two eyes? He rightly said that we can change occupation for him. Very, very good. I'm impressed with that answer. We can change occupation for him. We can teach him Braille, how to use Braille, to read, to read. You can teach him how to use Braille. You can change occupation for him. You can give him artificial eyes, but that's just artificial. If there is surgical intervention for him to restore his eyesight, they are doing them abroad, we can also be done for him. Thank you so much for that suggestion. Somebody has said erectile dysfunction. Yes, that is a problem. The impairment, disability, and then the handicap, kind of, if you like it or not, there is handicap in it. There are things like that are really not spoken about, not discussed, but we should still leave it like that. Let's look for other mainstream examples. Can I have one more example? Thank you for that. Okay, one more example, please. What about the man with leprosy, as we discussed? How do you describe his own disability?
Good evening, Doc. Good evening, Ma.
Good evening. Good evening. The
My
man
name.
with leprosy. The man with leprosy. Let's discuss him.
I didn't want to talk about leprosy. You asked another example.
Okay, I'm sorry. Just say your own example.
Okay, Ma, like a bricklayer that fell from a high place and suffered a spinal cord injury. He has been taking care of his family. Just one day he went out and maybe fell from a high place and had a spinal cord injury and other trauma that left him unable to walk again.
So what's the impairment there?
The impairment, the disability is inability to walk again.
What is the impairment? The impairment is the injury to the spinal cord. That's the injury. That's the impairment. All right. Then he's unable to stand up and walk. That's the disability. He's unable to walk. That's the disability. And of course, what he was doing before, he's a bricklayer or a painter or whatever. He can't do it again. He has become a handicapped person. Next slide, please. So we have talked about definition of impairment, disability, and handicap. Please read it yourself. You understand. Give yourselves examples. There are so many examples out there, not just these ones we have given. All right. Some of them are psychological impairments, anatomical impairment, physiological impairment, like diabetes now. The pancreas is not working well. That is impairment at the cellular or at the system level. That's impairment. Okay. All right. Next slide, please. Network is so bad, so let's run. Okay. Okay. We are trying to classify handicap, and we say there is extrinsic handicap, which is social. Anything extrinsic is outside the human body. Then intrinsic is inside the human body. But most of the things that are extrinsic are social handicap is not the fault of the person. Social, like a maternally deprived child, like a street child, like an orphan, AIDS orphan, for example, and a destitute, a beggar, all those ones are all handicap and they are extrinsic. They are social handicap. All right. Next slide. Why the handicap that is inside my body, like the fracture on the leg, the eye that cannot see well, the spinal cord that is severed, the pancreas that is not working, those are intrinsic handicap. All right. We also have intellectual handicap. That's the mental handicap. People have impairments at the developmental level. People can't reason well, can't think well, low intelligence. Okay. Their skill is poor. Some people are adults, but they have intellectual capacity of children. So intellectual handicap, mental handicap. Next slide. Okay. The people with intellectual handicap or mental handicap, they can be in three categories. Some can be educated and they can be trained, at least educable to a certain degree and be trained. Some cannot be educable. They are not educable, but you can train them. While some you cannot train them, you cannot even educate them. They are just existing, just there. You can't train them, you can't educate them. I know a child when I was growing up, she was just like a real imbecile. You know, she can't, it was difficult for her to even bathe herself. All right, so that one you can't educate her, you can't train her. But some you can train them in certain things. Some repair bicycle, some even learn to sew, some can cook. While some they can go to school to certain level, they can learn some things. That's the most common. All right, next slide. Okay, these are still examples of handicap. All right. Next slide, please. They're still talking about extrinsic, that social handicap like poverty, discrimination, segregation, racial, ethnicity, the people that segregate people from where they come from, like your race, your ethnicity. No, it's wrong. So they are saying that is you make them to become handicapped. All right. Next slide. What are the causes of handicap? There's a mnemonic that we used to use as students. We call it tin can bed. Tin, Tin, cam, CAM, bed, BED. So just write it downwards instead of horizontal. So write it vertically. Tin, Tin. Next to it is CAM. Next to it is BED. Then teen, like trauma. You know, one example is trauma. The other examples, I expect you to add them in. Teen, I like infections. And like neoplasia. Neoplasia are cancers. Neonatal problems. Nutritional problems. That's N. CAM, 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 chemical problems, chemical injuries. All right, that is CAM. Congenital problems. That's C. A, Arthritis, for example. There are other causes there. I can't remember now. Okay. Antenatal factors are also A. All right. Calm bed. Metabolic problems like diabetes. Metabolic problems under M. B is blood diseases, blood problems, blood dyscrasias like sickle cell disease. Sickle cell disease is actually genetic. That's not an example. Okay, so blood dyscrasias, blood problems, right? That's B. Then E is endocrine problems, endocrine problems like thyroid problems. Even diabetes can be put in that category. Cushing syndrome, Crohn syndrome, pheochromocytoma, Graves' disease, they're all endocrine problems. Then BED, D, what can D be? Diabetes, dementia. Okay, someone has chatted that A, accidents also. Dementia, that's the mnemonic. So if you have it, you can remember so many other examples and add to it. Next slide, please. Okay, it still continue. Next slide. All right, how do you manage? How do you manage? First and foremost, you need to make proper diagnosis. Like in the hospital, we say, take a history. Somebody is before you, you say, what happened? How old are you? How long has this been here? So you take a history. And as you're taking, was this since birth? How long family has it? Who else in your neighborhood has it? So that is taking history. All right. You take a history. Okay. Let me look at this now. Management. Let me see the slide before this one. Okay, we are done with this one. So next slide, sorry. Okay, they said usually by mothers, nurses, midwives. So you early detection usually when the child is born. As soon as the child comes out of the womb, cord is cut. Many midwives and obstetricians, as soon as they look at the child, they can notice one or two things. So usually that one that the child is born with, that is external, the person it can be seen. So midwives and obstetricians usually notice it as early as possible. All right. In advanced countries, they have what we call at risk register. That child that they notice has Down syndrome at birth, is quickly notified so that they will now put the child on at risk register. Then they will be visiting the family and be examining the child and advising when to go to see the doctor and all the activities that should surround that. So they keep a list of names of infants, children considered to be at risk of developing handicaps and are followed up, okay, back to school age and even more. They keep screening them, follow them up, okay. But here in this country, if you do that kind of thing, parents will be very angry with you that you say the child is has a problem and you have registered the child and you are following up the child. We have not gotten there yet. Okay, so next slide. Next slide, please. Okay, so you take history, do the examination, proper diagnosis, proper diagnosis, and you can refer for a specialist from the medical to the surgical. From the medical to the surgical, you can refer. Okay, if it's nutritional, speech, physiotherapy, whatever, you now refer. Next slide.
Sorry, Doc, I need to
Next slide.
do another screen, please. There is a mark that is showing there.
Okay, let's just go on and manage. You have the slide. Let's go on, please. If my slide is clear, though. Okay, today is the next time. Okay, next slide, please. Next slide. Okay, for children that are handicapped, you can send them to normal school. They attend normal school. You can send them to closed school. That is school for special children. Like school for the blind, school for the deaf. Okay, that's a closed school, a closed system. You can send them to the open school where other children are, or midway house. This is there are normal schools with special section for handicapped children. Okay. Next slide. Next slide, please. Okay, for vocational training, these are some of the things they learn. For employment, these are things they go through. Next slide. Maternal deprived children are also called motherless babies. Their maternal deprivation is when a child is deprived of the normal maternal care. Usually the child is less than 3 years old. Some mother child separation, multiple mothering, distortion in quality of care, institutionalization. I want you to browse it to know what that is. I don't want to know which areas practice and when do we practice. Okay, mother-child separation, like maybe the mother died, or the mother after having the baby has what we call puerperal blues. The mother's the mother mental state is not good, or the mother is there, the child is there, but there's distortion in quality of care. There are some parents, especially in advanced society, they are drug addicts, so they just shoot up and be high, and they forget they have children around them. The children suffer. Sometimes they lock them up. All right. Next slide. What are the options? Okay, the mother might be dead, child might be abandoned, okay? Abducted children from lunatics. Those are some of the children that are in motherless babies home. What are the options for care? The children that are in motherless babies home, what do we do with them? We can put them in the motherless babies home. That's the institution. Institutionalized care. Government takes care of them. Some people have some private ones too. All right. You can put them within care within the extended family with supervision from the social welfare. That means social welfare puts them, give them to their auntie or uncle or any relation, but they go to visit to know how the child is faring, or care with the extended family without supervision. So they just send them to live with their relations. And you can foster care very well abroad. So the child stays in a okay, and they supervise. And those that are related or non-kinship, those that are about that in Nigeria. Then there are some homes, SOS villages, or let the child be adopted by a family. Next slide. Then let's look at children, street children. There are children on the street, children of the street, abandoned children. Children live in the street with their families. I want you to also research this to know the difference between children of the street and children on the street. Very important to know the difference. On and off. On and off. Okay? I also see that people are just putting it in chat boxes to be asking me questions that they should answer. This is master's class. Somebody just said, what is SOS villages? If you type it in Google, you will get it. That is why you are a master's class. If I was teaching primary school, then I have to spell everything for them. I have to tell them everything, but that is master's class. I'm getting a lot of questions. Someone even said Tin Campbell, that after tin, he doesn't remember the other things. You can ask your classmates, but not to draw me back. So the difference between children on the street and children of the street, please, you need to know that. Next slide. Next slide, please. It's about to rain. It's dropping on me already. Outreach project, not drop-in centers, transitional homes, shelter homes. Okay. Let's look at the aged. Some people say it's aged. We can also say the correct thing is senior citizens. Individual who are 65 years and above. Okay. Individual who are 65 years and above. Please, can you go back to the last slide? Okay. 3 to 5% of population in Nigeria above 65, characterized by a decrease in functional capacity of the body system. Next slide. Okay, let's classify them. You know, some are socially aged. That is just determined by the country, like retirement. Some people 60 years and above is retirement age. So you will say that their age. Some people 65, some 55. Okay. Healthy age. We are classifying them now. Some have reached that 60 years and above, and they are healthy mentally, physically, socially, economically stable, healthy. And that's what everybody desires. Some are unhealthy aged. They might have acute illness or chronic illness. Some might have psychiatric or mental ill health. Some are destitute. Those are social problems. Okay, so for the unhealthy ones, they might have acute problems, they might have chronic problems. The lists are all there and not ending. Okay, someone has answered the SOS village. Very good. Next slide, please. What are the medico-social problems? Medico means medical and social problems. All right. Okay. So social problems, they are lonely. They let's not use poverty, but they lack money because they are no longer earning like they were earning before. They are no longer active in business as they were before. So their earning capacity is reduced. They are not employed, no more employment. Some are retired. They are underutilized. They have poor hygiene, some of them, medical problems, cardiovascular problems, diseases, and many others. Next slide. Okay, what do we think is number one social problem of people 65 years and above? Yes, Rosalind said loneliness. Rosalind said loneliness. All right. And somebody said I agree with it. Mercy also said loneliness. That's a serious matter. Can we have more input? What do we think is number one social problem? Oh, Promise is also saying loneliness. That's interesting. Can we vote, please? I want to know how many. It's very important to me. Depression from retirement, feeling left out, yes. That's interesting. Please, more, come in, more. Social isolation, neglect and abuse, loneliness again, discrimination, isolation, blurry vision, blindness, age-related, loneliness again, poverty, promises poverty, fear of what? Blessing, lack of companionship, yes, rejection, financial instability, Juliet said so, fear of unknown, yes, I don't know what that means. Yes, Linda said so. Fall, okay, fall. Linda said fall, yes. Insecurity, what kind of insecurity? Is it financial insecurity, social insecurity, or what? Samira says stereotyping, yes. Fear of abandonment, ageism, unnecessary fear. Oh, beautiful. So financial insecurity, poverty. Queenship says poverty again. Abandon, enemy. Okay. Okay. Fear of dependence on others. Corruption. The person will feel that abandoned. Pain of regrets. Nobody has typed the fear of dying soon, unemployment. Okay, you are all very correct, but I see loneliness. Fear of dying is there. Depression, yes. I see loneliness as being the most common. Let me crave your indulgence. Can you collect my WhatsApp from your class rep and let everybody just state just one answer, please? One answer, or you categorize your answer, 3 answers, 1, 2, 3. Number 1 should be the most serious, the most common, then number 2 and number 3. Let everybody send their answers to me, please. Let's collate it. It's very important so that we can start disseminating this information and teaching it and allaying people's fears. Thank you so much, this class. I'm proud of you. All right. So for medical, there are all those ones we have listed. Even drug addiction is there. So people cannot sleep without drugs, without painkillers. All right. Genitourinary tract infection, incontinence, cancers, nutritional deficiency, loss of teeth is very important. Okay. Loss of hair, loss of teeth, deafness, dementia, amnesia, schizophrenia, osteoarthritis, they are all common. Diabetes. All right, next slide. Okay, how do we care for the senior citizens among us? Individual, first and foremost, you must take the senior citizen himself or herself and reach to the person, educate the person in the language they will understand. Come down to their level. Tell them do's and don'ts. Encourage them to do the right thing. Health promotion, protect your health to prolong your life and live a healthy, interesting life. It's doable. Okay? Exercises, eat well, eat balanced diet. It doesn't have to be heavy, it doesn't have to be expensive, it just has to be clean and balanced. Okay? What to take out of diet, like excess oil, for example, excess salt, too much carbohydrates, too much refined carbs, refined food should be taken out of the diet. And of course, the person should be active. Move on your legs and move from one place to the other at least 30 minutes days a week. The person must be up and about. In doing that, your system pumping to every place. It's not just them, it's everybody. It's supposed to move, move, move. Okay, so regular exercise, avoid sedentary lifestyle, adequate sleep, appropriate diet, have a positive attitude to life, be more positive, less negative, less anger, less quarrelsome, forgiveness, all those things that will help your mental health. We should just incorporate it. Okay? And that's what to deal with the individual. Okay? So after the individual, regular health checkup, monitor blood pressure, sugar, cholesterol, vision, much more. Somebody has typed that. So the family should be taken on after that. Reach out to the family and read the riot out to them. Regular visit to the elderly person, interaction, call, visit, care for them, no abuse. They need to know what an abuse and mistreatment is. If you can't reach them, send them the literature or say, read up this. They will go, everybody is internet savvy now. They will read it up and know what elder abuse and mistreatment is. They will read it up. Okay, or you can send them the literature. So they should avoid being labeled as abusers of elder. Okay, so they can be reached out. Then they should take care of their family, their elder persons. Not when they die, they put on canopy and much more. Take them for regular checkup. Make sure they refill their drugs. Make them still the head of the home. Consult them from time to time. Chat with them. Make them feel wanted. Just like we have identified loneliness. You know, many of them think they are no more relevant. Nobody wants to hear from them, and want to hear from them. Let them know that they are still the master of the house. They are still the father of the house, the mother of the house. Still much more. This is the family. Next slide.
Okay, so the talk was logged out of the meeting. So let's just hold on.
Ana lectures har yanzu ba. Kin san Allah ya taimake ni ne?
Please, we need to remain muted because I had to mute everybody so that she can be able to speak when she comes back.
I'm back. They locked me out. I'm back. Okay, we're almost there. We're almost at the end. I'm back. So community neighborhood facility visited by religious leaders and NGOs, government daycare centers. In some countries, they will say it's for them. Effective for the elderly, free or so. Next slide, please. Next slide. We're almost done. Next slide, please. Okay, destitutes are individuals who roam around without any visible means of livelihood. They lack the basic necessities of life. Destitution connotes extreme poverty and deprivation. Categories are able-bodied. Some are able-bodied. Example are migrant workers or economic migrants. Okay. Disabled, destitutes, the blind, the deaf, people that are begging, crippled, drug addicts, they are disabled destitutes. There are people that are aged and destitute, they don't have family to care for them. So they're just on the street. There's nothing wrong with them other than they're aged and they don't have income, nobody to care for them. So they are aged destitutes. There are also displaced persons that are destitute and beggars. Next slide. Beggars, almajiris. Do you know what is almajiri? I'm sure we know. You know, most of them are not destitute. They still go home. They have places that they come from. But a few of them are just on the street. Just like even in Port Harcourt, we have street children. All right. Next slide. Okay, this we already discussed this. It's like it's repeated. Next slide. How do you manage it? How do you control destitution? Provision of job opportunities. Okay. Increase public enlightenment about people's rights, privileges, and problems of destitutes. Provision of rehabilitation, social welfare, and educational facilities. Discouragement of street begging, especially in school-age children, adults exploiting children should be prosecuted. Next slide. Establishment of community-based training center for destitute, establishment of more institutions for the handicapped, help in peacekeeping and stability so that there won't be internally displaced people. Next slide. Okay, we are done for today. Well, part of our topic is not juvenile delinquency. We are done for today. Any questions? Next question. Any questions? Well, I think we are done for today. This juvenile delinquency is not our topic. Any questions?
Okay,
No,
so
ma.
Doc, are we
Okay,
going to have
thank you so much. Can you do what?
are we going
Ma,
to
we
have another?
understood everything you said. Thank you.
Yes, I always encourage you to read, then you understand and apply. apply it to what you already know and practice it. That's what I usually encourage.
Thank you.
And I tell you to read more, think more, read more, make your notes.
So, Doc,
Any other contribution?
Doc, are we having another
Thank
class
you, ma.
tomorrow?
All right.
Ma,
What's
Thank you,
the
Bob.
I have a question, please.
Sunda.
Please,
go ahead.
for the poses, you said that the juvenile delinquency is not part of the topic. Are we supposed to read it?
No, but no, I didn't say you shouldn't read it, but it's not part of my topic. So since it's in the slide, read it for your knowledge. But I won't set it. It won't be my question because it's not part of my own topic. But read it for your information.
Okay, so Doc, I'm asking, are we having another class tomorrow?
No, we are done.
Okay, all right, thank you.
Is there any slide? We have all the slides. We are done.
Thank you,
If there's
ma.
any question, private chat me. Anything you don't understand. But people should share the slides that they have. Thank you so much.
Assignment.
Thank you.
Good night. I'm sure
Thank you,
I've kept some of you from. Thank you. I've kept you away from doing your night.
Thank you, ma. Thank you so much.
Bye.
Thank you, ma.
Bye.
Good night.
Thank you,
Bye.
ma. Good night, ma.
Bye, ma. Good night, ma. Thank you.
Thank you, ma.
Thank you, ma.
Good night, ma.
Thank you, ma.
Thank you, ma. Good night.